Uh, I would like to invite Dr. Humeira Iqbal, who is worked for nearly 10 years as a consultant respirologist at Royal Alexandra Hospital in the Division of Pulmonary Medicine. She not only worked, but she also supervised clinical students and residents and fellows as a pulmonary clinical assistant professor under the University of Alberta. Dr. Iqbal holds many leadership positions, most notably in her work as a pulmonary bronchoscopy lead, pulmonary clinical assistant lead, and deputy chief of pulmonary medicine at Royal Alexandra Hospital. Her clinical interests include providing comprehensive care for patients with COPD, asthma, ILD, and sleep apnea. Please welcome Dr. Humeira Iqbal.
So I have no disclosures that affect our talk today. So I was asked to present asthma management and COPD management, which of course, I cannot present the entire in detail, but I'll try to focus on the current guidelines for both asthma and COPD. Today's learning objectives are to apply strategies to help improve asthma and COPD patient outcomes, relationship between COPD exacerbations and cardiovascular disease, family medicine awareness of biologics, and referral readiness for asthma and COPD, understanding epithelium and its alarmins and cytokines in the manifestation of inflammation in COPD versus asthma. So what is COPD? COPD is a heterogeneous condition that is characterized by chronic symptoms and chronic airflow obstruction. The chronic airflow obstruction is caused by small airway disease as well as emphysema. Early identification is very important for proper management of COPD patient. In one of the family medicine studies, about 50% patients were diagnosed late, and at the time they have 60% had moderate COPD diagnosis. Now, who should we test? According to the GOLD guidelines, patients who have symptoms of dyspnea, chronic cough, chronic sputum production, family history of COPD, as well as risk factors for COPD. As we know, smoking is the most common risk factor, but there are other risk factors, including home cooking, heating fuels, occupational risk factors, dust, vapors, fumes, gases, or other chemicals. So GOLD recommend to perform a spirometry in patients with symptoms or risk factors, but not a screening spirometry. So this is a pulmonary function test for one of my patients. I'll see if the pointer works. Has anybody seen a pulmonary function test before? Yeah. Okay. So just briefly, comprises of three parts: spirometry, lung volumes, and diffusion capacity. So spirometry, the diagnosis for COPD, we need a post-bronchodilator FEV1 to FVC ratio. Post-bronchodilator is 26. This shows that there is obstruction. Now, to grade the severity, we look at the FEV1 post-bronchodilator, and 29% is severe, very severe obstruction. Then we look at the bronchodilator response. A bronchodilator response of 12% or more than 200 is considered a positive response. The next, quickly go to the lung volumes and look at the TLC. A TLC of 80 to 120 is considered normal. 113 is normal range. And then lastly, we looked at the diffusion capacity adjusted for VA, and 35 is considered low. For everything, 80 to 120 is normal. So in a nutshell, this patient has very severe COPD with bronchodilator response and emphysema subtype. So a COPD is a complex and ever-evolving disease with generally poor prognosis. Routine, regular follow-up is very important. Even with the best possible care available, lung function can decline over time. So when you see a patient for initial assessment in your clinic, it's always good to first confirm the diagnosis of COPD with a pulmonary function test. Once you have done the diagnosis, then you grade the severity into mild, moderate, mild, moderate, severe, or very severe. Then the further management, I will go more in detail once I discuss the CTS guidelines for management of COPD. So as I mentioned that these are the gold rates and severity of airflow obstruction. I'm pretty sure that people have seen this grades before. Grade 1 is considered as mild COPD when the FEV1 is greater than 80%. Moderate is 50 to 80%, and severe is 30 to 50, and very severe is less than 30%. We can see that our patient lung function, does anyone remember what was the lung function? It was 29%. So that patient was very severe COPD. There are two very important questionnaires for COPD assessment tool. These are validated and universally agreed upon scores. One is called COPD assessment tool, and the other is the MMRC dyspnea score. COPD assessment tool is basically assesses the effect of dyspnea on patient's life and how it impacts their life. Does anyone use a CAT score in their clinic? Good. Okay. So you can actually give it to your patient while they're waiting. If you know it's a COPD patient that's going to come for follow-up, you can ask your MOA to give them while they're waiting. And if you track them over time, you will see that if their initial, the score of 10 is considered significant. If they come now in your clinic and the score is 30, they're having a bad day or there is an exacerbation. MMRC dyspnea scale is a very simple question. You just ask the patient what makes them short of breath. I usually ask them, if you go to walk with your wife, are you behind them, considering that their wife is in good health? And if they tell you that they are slower, then it is MMRC grade 2. MMRC grade 2 dyspnea is associated with exacerbation and is considered a very high symptom burden. In Canada, we follow the Canadian Thoracic Society guidelines, and the Canadian Thoracic Society guidelines have recently published an update to the management of stable COPD. Now, what is stable COPD? It excludes any acute worsening of dyspnea or any acute exacerbation. The goal of the therapy is to elevate dyspnea, improve health status, and prevent COPD exacerbation and reduce mortality. It is not a step-up approach. It's actually the treatment of the patient at that moment, and it doesn't follow the pattern in a stepwise approach. So let's go over this. So there are 4 categories in assessment of a patient. First is a lung function impairment. Lung function impairment goes from mild to very severe. So you draw the cross where your patient's lung function is. Then assess the symptom by the MMRC dyspnea score or the CAT score. And then you can see they're pointing at different levels. Then last, you ask the patients if they had an exacerbation. So once you have plotted, you basically treat the worst and consider applying the above layers of management. Now, going above in the self-management, we know that every patient should be counseled for smoking cessation, rehab, vaccinations. Then you go above and inhaled maintenance and preventative pharmacotherapies, which are basically inhalers that are used in COPD. Going further, pulmonary rehab is considered for all the patients. The oral pharmacotherapies that are available are oral macrolides and oral phosphodiesterase inhibitors. Going further, if the patient has hypoxic respiratory failure, use oxygen. But if they have hypercapnic respiratory failure, then BiPAP or positive pressure ventilation could be used. Then further treatment is a lung transplant referral and surgical endoscopic therapies. So this is the COPD pharmacotherapy. You divide patient into mild, moderate, and severe. So mild patients are the ones who have less symptoms and less risk of exacerbation. So for them, a single bronchodilator is good enough, like LAMA or LAMA therapy. Then you go to moderate and severe. And if they are low risk of exacerbation, which means that they did not have an exacerbation in the last year, you put them on dual therapy, like a LAMA-LABA combination. And a severe or high risk of COPD patient is the one who has a severe exacerbation in the last year. And I'll go over what is considered a severe exacerbation. And those patients are directly started on a triple therapy. So this is the, I'm hopeful that the family physicians are familiar with some of the inhalers in this chart. So these are most of the inhalers that are used in patients with asthma and COPD. In the bottom here are the two triple therapies. So one is which is ICS, LAMA, and LABA, Breztri, and Trelegy. If it is asthma, we have another triple. But for COPD, only these two triple therapy inhalers are approved. This is a LAMA group, this is a LABA group, ICS, LABA, and then the short-acting inhalers. The two trials that were used for the triple therapy were the ETHOS trial and the IMPACT trial. And both these therapies are effective in about 24% relative rate reduction for a Breztri and 25% relative risk reduction for Trelegy in compared to the ICS LABA and the LAMA LABA component. Now, just touching with this is actually the GOLD guideline, just one slide from the GOLD. GOLD has a little bit different approach. So I'm pretty sure you must be familiar with the A, B, C, D GOLD categories. Now, what they have changed here, instead of the C and D, they just put an E for an exacerbation. So if anyone has an exacerbation greater than 2 moderate or 1 severe, they are in the E group and they suggest a LAMA LAMA. They don't add an ICS unless your eosinophil count is greater than 300. So this is the only thing different in the new GOLD guidelines. Oral therapy, as I mentioned, is chronic azithromycin therapy, 250 milligrams daily, or 500 milligrams 3 times a week could be used. You have to make sure that certain things have to be ruled out before someone is started on azithromycin therapy. It can make sure that you check their hearing, do an ECG to assess for prolonged QT. And one more thing is to have a sputum sample and make sure they don't have Mycobacterium avium complex in their sputum. Phosphodiesterase 4 inhibitor is also used in COPD. If one oral therapy doesn't work for a year, you can switch it to another oral therapy. I don't use it that much. It's a special phenotype you can use. And those are the patients who have chronic bronchitis and have high risk of exacerbation. Diarrhea and weight loss is a common side effect. Now, COPD is a vicious cycle. The airflow obstruction leads to dyspnea, and further inactivity can cause exacerbation, which can further lead to airflow obstruction. Let's dive into what defines an exacerbation. So, worsening of symptoms and and exacerbations are hallmark of COPD. Exacerbations are classified as mild when there is worsening of symptoms but no change in prescribed medications. Moderate when they're prescribed oral corticosteroids and antibiotics. And severe is when there is hospitalization or presentation to even emergency visit. It has been reported in Canada about 70% of patients will have one moderate or severe exacerbation in 3 years period. But about 68% of these exacerbations, they go unreported because of the stigma associated with worsening respiratory symptoms and COPD. The effect of exacerbation goes beyond the lungs. In this summit trial showed that patients with COPD have increased cardiovascular risk. And when I talk about the increased cardiovascular disease, that not only include MI, but also stroke. The risk is highest in the first 30 days, but it persists till the 1 year mark. It is highest with moderate, it's 4 times, and with severe, it is 10 times risk of having a cardiovascular event. Cardiovascular pulmonary deaths are a common cause of mortality in COPD, and in this European study, across 5 studies, up to 30% deaths were due to CV causes. Now, what is the role of primary care in COPD? So first is if you see a patient who has symptoms and has risk factors suggestive of COPD, make sure you don't give them a sample inhaler. Try to get a spirometry. I usually do a pulmonary function test. I don't know what the availability of pulmonary function test is in other provinces, but in Alberta, we are able to get it done quite quickly. Once you have established a diagnosis, then you start patient on an inhaler therapy based on the guidelines. And then every visit, you check patient's adherence and the inhaler technique, maximize therapy as per the guidelines, and you can refer to a respirologist anytime when it's appropriate. Okay, switching gears quickly to asthma. So about 3.8 million Canadians have asthma. 5 to 10% have severe asthma. Asthma is an episodic condition. Because it is caused by allergens, the symptoms are episodic. There could be dyspnea, chest tightness, wheezing, and sputum production. So this is the normal airway, and this is an asthmatic airways. You can see airway narrowing, thickening of the wall of the mucosa, and tightening of the smooth muscle. Most of the time, asthma goes unreported. Patients present to emergency with respiratory symptoms seen by emergency physician, given oral corticosteroid, discharge home without any inhaler therapy, and they go back again with an exacerbation. So the GINA international guidelines are the one we use for asthma. GINA has 2 tracks. So the preferred track is the track 1, and this is the one in which you use the air therapy, which is anti-inflammatory reliever. Simple terms, you use Symbicort as a reliever, and then stepping up, you can use as needed, low dose Symbicort, medium dose Symbicort, and then you add LAMA at step 5, and then there are biologics that I'll touch for a brief introduction to biologics. The track 2 is a less preferred one, in which Ventolin is used as a rescue preferred. It is less preferred because it has shown that without an ICS, there is an increased risk of exacerbation. You can use track 2 in a patient who is well established on inhaled corticosteroid and has no exacerbation in the last 1 year. Exacerbations are common regardless of asthma severity. They happen in a patient who have mild asthma. They can happen in a patient with adherence, excellent adherence, and they can happen in a patient with excellent asthma control, because again, asthma is unpredictable. It is caused by an allergen, and anytime you have an exposure to allergen, you can have an asthma exacerbation. What can primary care do in asthma management? So, first of all, try to get a diagnosis with a pulmonary function test. Make sure you start patient on therapy based on the GINA guidelines, and then you make sure you assess SABA reliance, like a Ventolin reliance on these patients, because SABA reliance has shown to increase mortality in asthma patients. So I'll do a brief introduction to biologics, understanding the inflammatory cascade. About 10% of adults and 2% of children have severe asthma. Severe asthma is the asthma that is not controlled despite maximum ICS LABA therapy. There are multiple drivers of asthma. I don't know if you're aware of asthma phenotypes. So there is an allergic phenotype. This is at the level of epithelium, where one is caused by allergens. The second one is eosinophilic. The third is non-T2 inflammation, and then T2 and non-T2 inflammation. So type 2 inflammation is 2 minutes. Type 2 inflammation may drive disease in up to 88% patients with severe asthma and up to 40% patients with COPD. The symptoms are almost similar. Let's quickly go over the available biologics. So who should we start biologics on? Usually we start biologic if asthma is not under good control despite maximum ICS and inhaler therapy, if they have eosinophilic or allergy component, if they are predictor of enhanced response, if they have coverage, and if they're okay to take injections. These are the available biologics in severe asthma. So just briefly going through, omalizumab is the oldest biologic available, and this one is used for allergic patients. So they should have a skin allergy or blood allergy test positive for asthma. Benralizumab, called Fasenra, Mepolizumab, called Nucala, is used for patients with severe eosinophilic asthma. Resolizumab is an IV. The advantage of this is its dose is weight-based, so you can give to patients who are overweight because it's IV. Dupilumab, called Dupixent, is used for asthma as well as for nasal polyposis. And the last one is the anti-TSLP called Tespar, which acts high up in the cascade, and it is used it doesn't need any eosinophilic or allergic component. This is the inflammatory cascade for COPD. Just a couple of slides more. So biologic targeting IL-13, IL-4, TSLP, IL-33 are being studied and moderate to very severe COPD. These agents affect multiple pathways, and hopefully by next year we will have one of them available, and that's going to change management of patients with moderate asthma and moderate COPD with recurrent exacerbation. So my summary is obtaining an early and thorough diagnosis can help improve COPD and asthma patient outcomes by ensuring we are treating the right disease. Recognizing the danger of exacerbation in both asthma and COPD can improve patient outcomes by optimizing therapy as per guidelines. And awareness of biologics of asthma at the primary care level so they know when to refer the patient in a timely manner. And understanding the epithelium and its alarmins and cytokines in the manifestation of inflammation in asthma and COPD has led to the development of biologic therapies and which has broadened the treatment for these patients. Thank you.